Hi, everyone, and welcome to today's session. I'm so excited to introduce our speakers for today. Our speakers for today are going to be Fung An, Kripali Patel, Amy Dawson, and Alyssa Puya. And I also wanted to share a little bit about our speakers. Fung An is a pharmacist and is an associate professor of pharmacy practice at the Massachusetts College of Pharmacy and Health Sciences, and the Community Engagement Coordinator for the School of Pharmacy, Boston. She also serves as a clinical pharmacy specialist at Codman Square Health Center in Boston, Mass, where she works collaboratively with the primary care team to manage patients with chronic diseases. Dr. Kripali Patel is also a pharmacist and is an assistant professor of pharmacy practice at MCPHS, University in Boston. A graduate of MCPHS herself, she completed a PGY1 community pharmacy residency at the University of North Carolina and a PGY2 residency in geriatric pharmacotherapy at Virginia Commonwealth University. Dr. Patel currently practices as an ambulatory care clinical pharmacy specialist at Whittier Street Health Center in Roxbury, focusing on managing chronic conditions such as hypertension, diabetes, high cholesterol in conjunction with physicians. If you could go to the next slide, please. Dr. Amy Dawson is an associate professor and vice chair department of pharmacy practice at MCPHS in Worcester. Alyssa Puya is a clinical pharmacist at the Holyoke Health Center, an FQHC in Massachusetts. Both are certified diabetes care and education specialists and provide direct patient care at the health center via collaborative practice agreements with prescriptive authority for type 2 diabetes, in addition to other chronic disease states. We're so happy that you're all here today, and we can't wait to see these presentations. Thank you.
I'll go ahead and share my screen. Thank you, Jessica, for the introduction. So I'll get started. Hi, everyone. I am Fung An, and I won't go into my background because Jessica was able to do that for me. But I'll get us started in this presentation. Just want to let you all know that Kripali and I do not have anything to disclose. By the end of this presentation, or at least this portion of the presentation, we're hoping that you'll be able to identify common causes and types of medication-related errors during inpatient admission and discharge that might impact patient safety and transitions of care, and then discuss strategies in preventing and resolving medication-related errors to improve patient safety during transitions of care. And we'll highlight some of the diabetes aspects during this time. Please keep in mind that while, the objective is saying inpatient, really thinking about how it's not just the hospital, it could be any facility that your patient might be admitted to or staying for a period of time. So when I'm referencing or when we're referencing inpatient during this presentation, please keep in mind that it doesn't just apply to inpatient as well. It can also apply to other settings. With that being said, I wanted to just give some background information. What is transitions of care? Basically, it's when a patient moves through the different settings, whether that be within the same institution. So what I mean is if the patient is in a hospital, if they're moving from the ED to the med-surg floor, that's a transition. Or typically when you think of transitions, you think of a patient getting discharged from a hospital back to home, or discharged from a hospital to a SNF, long-term care, whatever it is. But basically when a patient is moving from one setting to the other. And the way I think of it is if we're transitioning a patient to from one provider to another provider, that is a type of transition. There's various different terminologies that's synonymous. So transitions of care, care transitions, and continuum of care. So why does it matter? Every transitions really counts because there's certain things that we want to think about. So if you're working at an institution, an organization, there's compliances that you have to meet in order to either be rewarded something, typically a payment, or there's a reduction in something such as payment. And so you can see here that there's several Medicare, Medicaid services that looks at different interventions that's related to transitions. And then there's also the Joint Commission. There's also national organization that looks at best practices related to interventions that impacts patients' transition. And then there's what we care about the most is patient care. There's a patient care aspect of transitions when patient transition from one setting to the other. We'll talk about it a bit, but there's communication issues, there's care coordination issues, there's med management issues, which is the focus of this presentation, and then there's patient caregiver engagement and education. And so there's both regulatory and quality programs related to transitions that we care about, but there's also patient outcomes. In terms of transitions of care, so the reason why we focus on transitions of care and med management is that medication errors typically happen during patient transitions. You can see here, this is the definition of medication error, but basically it's something that's preventable that may cause or have or will cause harm to your patient as it relates to medication. Um, Implications of medication errors. So medication errors typically happen during care transitions, like I mentioned before. You could see the stats in the little bubbles there, but there was a study that saw that 14 to 20% of patients get readmitted to the hospital due to some sort of medication error. And in particular, that's the 14 to 20% is patients with diabetes. In general, adverse drug events occur in patients discharged from a hospital in about 11% of patients. Keep in mind that 27% of that 11% is actually preventable. And so when we're looking at implications of medication errors, especially around transitions, patient transitioning to one setting to the other, we think about potential patient harm, like I said, and actual patient harm. So those actual patient harms are things like the adverse effect, the hospital readmission, the ED visits. It can cause prolonged length of stay in a hospital. In worst case scenario, it could potentially cause death. Some other things we think about is dissatisfaction. So if there is medication error, you can guarantee that there might be patient and provider dissatisfaction in that area. And so I wanted to talk about common causes and types of errors. So I did allude to this already, but errors happen, especially medication errors during care transitions. We talk about, I mentioned about how the focus of this piece of the presentation is kind of inpatient transitions. And so typically what happens is when a patient gets admitted, there's some sort of medication error that happens because we have an incomplete medication history. We might be missing outpatient medications that the patient's taking. On discharge, the patient might have an incorrect med list. There might be unclear instructions, there might be duplications, things like that. And so we'll talk about that during the next few slides. So what are the types of common medication errors? So there's reconciliation errors. So we hear about medication reconciliation all the time. And that's something that's very important to do, especially when the patient is transitioning from one setting to the other. Because if we don't do that, there tends to be a lot of different errors, medication errors that can happen. So when I think about reconciliation errors, medication reconciliation errors, I think of it, I put it into 4 different buckets. There's errors of omission, errors of commission, duplication, and discrepancies in the dose frequency and formulation. Medication reconciliation errors tend to happen when there's an unintentional discrepancy between what the patient's actually taking versus what they should be taking. So what the providers had ordered or prescribed. Error of omission is that you're missing a necessary medication that the patient should be taking. So for instance, an example would be stopping a chronic medication unintentionally. So in the thinking about diabetes, right? Maybe we unintentionally stopped metformin for whatever reason. Error of commission is basically prescribing unnecessary medication. So it might be an inappropriate continuation of a medication that's intended only for a specific setting. So from a diabetes standpoint, sometimes we hold the patient's oral medications while they're in the hospital. We give them temporarily insulin while they're in the hospital, but then we want to discontinue insulin, put the patient back on metformin, but say we accidentally continue the insulin, that's an error of commission where we're prescribing something that maybe the patient shouldn't be on. Duplication, basically prescribing the same medications with the same therapeutic effect. So thinking about, inpatient admission, a lot of times what happens in the inpatient setting is that medications that the patients are at home may be prescribed as a different medication that has the same therapeutic effect that's on formulary at the hospital. So a good example is a statin, right? Say the patient is on rosuvastatin at home. In the hospital, atorvastatin is on formulary, so the patient is temporarily on atorvastatin until they get home. What would happen is the patient's supposed to go home on their home medication, and the formulary medication in the hospital should be discontinued. But sometimes there might be an error in terms of starting the hospital statin, and so the patient would then go home with two different statins, for instance. And then discrepancy in dose frequency and formulation. So that would be things like, patients should be on metformin 500, but then they're being prescribed metformin 750, something like that. So that's like a discrepancy in dose. And then there's therapy related errors. So there's reconciliation errors in terms of discrepancy between what the patient should be taking versus what the actual patient actually taking. And then therapy related errors are things like dosing errors and failure to treat. So dosing error is, for instance, say a patient has kidney disease and the medication needs to be dose adjusted for their kidney disease. And maybe that wasn't adjusted. And so that would be potentially a dosing error. Failure to treat is basically what it is. Say a patient has high blood sugar, they have diabetes, they're not on anything for diabetes, but that really needs to be addressed. So that's kind of what the failure to treat means. The most common medication errors during transitions of care for patients with diabetes is basically omissions of medications for diabetes. So we're not giving the patient medications for diabetes. Incorrect dosing or failure to adjust for renal function, nutrition, or acute illness. So if your patient is sick, oftentimes their blood sugar is higher, and so you have to adjust medications for that, and sometimes that might not be happening. Inappropriate continuation or discontinuation of insulin regimens. So I gave you an example of how a patient may not be on insulin at home. They might just be on oral diabetes medication, but while they're in the hospital, they held those oral medications and just put the patient on insulin while they're in the hospital. And it may be accidentally prescribed at home when the patient truly don't need it. And then there's discrepancies in insulin type or administration timing. So what that means is there's a lot of different variations of insulin. There's short acting, rapid acting, long acting, so on and so forth. And there's a lot of different brands as well. And so there might be a discrepancy in which one the patient should be taking versus what they're actually taking. And then administration timing. So, is the patient supposed to take it at night? Is the patient supposed to take it in the morning? Did those change while the patient was in the hospital? Was that communicated to the patient? So these are the most common medication errors you see for patients with diabetes. So why does this happen? Communication is huge. Oftentimes medication errors happen during care transitions due to poor communication. Poor communication can happen in two different buckets. One of the bucket is poor communication between the healthcare provider as well as the patient or caregiver. I like to loop in the caregiver. I like to put patient slash caregiver because, as you all know, sometimes it's not the patient that's managing their medical care or their medications. It might be a caregiver. And so that's kind of why I lump those two together. But oftentimes, what happens is patients are educated on something that they should be doing at home. Um, but the problem is there might be poor communication. So a good example is when I used to be inpatient doing patient education on discharge. When a patient's getting ready to leave, that's all they could think about. They're like, I'm ready to leave. So if you're educating them at that point in time, they might not absorb and retain the things that you're telling them. And so there could be a lack of a disconnect between what that healthcare provider is telling them versus what they absorb. And so that is an area where poor communication can happen that could potentially lead to med errors because your patient or caregiver may not know exactly what they should be doing at home because they might have forgotten their instruction, or the instruction might not be clear and that wasn't evident to the provider to clarify that. And then poor communication can also be from one healthcare team member to another team member. Good example, talking about inpatient to outpatient discharge. Maybe the inpatient provider discharged the patient on these medication changes, but it was never communicated to their outpatient provider, their primary care provider. And so there's a huge disconnect. So then when the patient goes see their primary care provider, the primary care provider may assume that they might be on, an old medication that they shouldn't be on anymore. Luckily with us, a lot of the institutions in Massachusetts now have Epic, and so we're able to see some of those electronic health record, but that isn't always the case. And so there is potentially a disconnect in terms of communication from one provider to another, especially when there's medication changes. Incomplete or inaccurate medication reconciliation. So medication error, like I mentioned before, is huge when medication reconciliation isn't done properly. If you don't do a proper medication reconciliation on admission, what you're going to find is you're going to potentially continue medications that's not appropriate in the hospital. And then you're going to continue potentially that medication on discharge. And so it's very important to do an accurate med rec in the beginning, so that it doesn't trickle down to on discharge. And then lastly, lack of structured discharge planning. And so if there's not proper discharge planning, there might be communication issue. A lot of times that is poor communication to the patient around discharge planning, but potentially to one provider to the other provider as well. One of the things we talk about in the transitions of care world is if a patient gets discharged from a hospital, they really should follow up with their primary care provider within a week of discharge, sometimes even earlier, depending on your high risk patients. But what if that discharge planning falls through in terms of care coordination? Who's actually making that follow-up appointment, right? Are you asking the patient to do that, or are you booking that appointment for your patient? And if you're kind of waiting for your patient to book that appointment, they might not book that appointment. And so they might not go in to see their primary care provider at that point in time when they should. Um, So I'm going to go ahead and transition over to Kropali, who will talk about strategies to prevent and resolve some of those areas. And I know that I kind of alluded to some of them already, but she'll hone in on those interventions.
Good afternoon, everyone. Thank you so much for having me here today. So as Fung mentioned, I'll be talking about strategies to prevent or adding to strategies to prevent and resolve errors. So um, if we could go to the next slide, perfect. So in terms of preventing resolving errors, before we go into that, I wanted to talk a little bit or provide an overview of what medication reconciliation is, which is essentially a process aimed at preventing these types of errors. Medication reconciliation ensures that there's accuracy across transitions and prevents medication errors. In terms of how we do a medication or conduct a medication reconciliation, typically we want to have as many sources of medication information as possible. So this could include items like patient family interview, medication vials, or lists that they may have from prior primary care visits or discharges. And then PMP or prescription monitoring program may provide some information around controlled substances. And then also digging into the electronic health record can give us some more information. Ultimately, once we have all of this information, we'd want to conduct an interview with the patient themselves and ensure that everything is accurate. And this then gives us our best possible medication history, which is also abbreviated as BPMH. And then this will kind of help us order any medications that the patient may need in the hospital or the rehab or wherever they're at. And then the same process typically should take place prior to discharge. So we should be reconciling what the patient came in on from home and then what they're going home on and make sure everything makes sense. For example, we may have formulary changes. If the patient is on simvastatin at home and it's not on formulary, they may be changed to atorvastatin. And we want to make sure before they go home, they go back on the simvastatin. So once all of that is all set, then the patient will have their discharge plan in hand. So there are a lot of folks that play a role in this process, obviously. And here's where I'll talk about the roles and responsibilities of the key team members. So of course we have nursing, and typically nursing will collect the medication history at bedside and develop what's called a prior to admission medication list, which helps providers start putting in orders, et cetera. And then also maybe responsible for patient education as well. In terms of pharmacy is typically responsible for the medication reconciliation. So identifying, those omissions, duplications, et cetera, formulary substitutions, as we've talked about, discharge counseling. And I know that I've laid out these roles and responsibilities here, but sometimes we do have overlap or sometimes, with time constraints, et cetera, somebody may be pulled to something else. And in that case, it's fine for us to step in. For example, there have been times where, nursing staff is really busy and pharmacists will get pulled in to do patient education, et cetera. And then we also have case management, social workers and community health workers who help coordinate follow-up, address any barriers that the patient may have in terms of discharge or optimizing care. And our physicians who are going to write the orders and prescriptions, as well as confirm the final medication list. And then we'll go into practical tools and approaches. So in terms of interprofessional implementation strategies, we have a couple toolkits that have been around for some time and have been really well studied and work really well. So the Marquis study was a multi-site prospective quality improvement project, which was conducted here in the US. It implemented a standardized toolkit that included best practices, process maps, staff training, patient caregiver interviews, pharmacist involvement at admission and at discharge. The aim of the study primarily was to decrease unintentional medication discrepancies, which is a major cause of preventable adverse drug events during transitions of care. We also have the MATCH toolkit, which was developed by the Agency on Health Research and Quality. And the aim for this was to reduce medication discrepancies when patients move between care settings again. It provides a detailed roadmap for institutions to be able to assess their current practices, identify what the gaps are, and then build out standardized medication reconciliation workflow. The approach to this toolkit is assess, design, pilot, and spread. So essentially looking at what we already have going on, reevaluating, piloting, and then spreading the good practices. If both of these are really great if your institution is looking to implement a MedRec program or even optimize their medication reconciliation program. And I think the biggest key with any program in terms of MedRec is using continuous auditing and feedback for quality improvement. In terms of standardized templates, both the MATCH toolkit and the Marquee toolkit both have checklists to help standardize the best possible medication history process and the reconciliation process. In these templates, the roles are clearly defined for nurses, pharmacists, and physicians, and it does help improve communication and accountability overall. In terms of discharge counseling and teach back, we want to make sure that we're providing the patient discharge counseling, but I think it's really, really important that we really start the education piece as early as we can. As Feng mentioned, usually as discharge, patients are getting inundated with information. Sometimes discharge is not that well planned out, and it can be a huge burden on the patient. They may not remember everything we're going through, et cetera. So ideally, if we can provide education and teaching throughout, that's great. But in terms of specifically discharge counseling and teach back, we want to try to use the teach back method. So have the patient reinstate the instructions, and not only stopping there, but having them also demonstrate the technique to confirm their understanding. Pharmacist-led medication counseling improves knowledge and reduces post-discharge errors. And again, collaboration is key to make sure we're enhancing adherence and safety. So a great example I can give of this is oftentimes patients are discharged with glucometers and providing a teaching for the glucometer, either by the pharmacy team or the nursing team, is really, really helpful because there are a lot of pieces to a glucometer and it can be overwhelming for the patient. So walking them through the steps and then having them also demonstrate to us that they're able to check their blood sugar and feel comfortable doing so. And then in terms of managing inpatient and outpatient formularies, this is really going to fall on the pharmacy team for the most part, but making sure that we make the appropriate changes that are needed. And this is really going to start at admission. So if we don't have an appropriate, an accurate admission medication list, that's going to follow the patient throughout and potentially to discharge. So it really starts at admission, making sure we have the accurate medications and making the accurate interchanges in terms of the hospital formulary, rehab formulary, et cetera, and ensuring that the patient is going home on the appropriate outpatient regimen. Making sure that if there's a new medication being started or medication being changed, that it's covered by the insurance and the patient is not going to have any issues picking up at the pharmacy. And again, kind of alluding to that, so we want to make sure, when the patient is discharged, either from the hospital or from rehab, that we are making sure that their medications are covered, conducting a proactive drug use review or utilization review prevents coverage and safety issues. I often see at the pharmacy a patient comes out of the hospital and they're put on a CGM, et cetera, but that particular CGM is not preferred by their insurance. So then the patient is having to go without one until they potentially follow up with their endocrinologist or follow up with their primary care doctor, and it just doesn't make for good patient care. So in that case, warm handoffs can really ensure communication with outpatient pharmacies and providers. So if we know a medication may not be covered, are we able to provide a supply until the prior authorization is done, or could we at least let the primary care team know or the specialists know that this is a pending issue? And then high risk identification. Ideally, we want to be able to conduct medication reconciliation on all of our patients who come in, but sometimes we are stretched for resources, staff, et cetera. And so we may need to prioritize our patients. So one way to identify high risk patients are by their certain risk factors. And some of those could be polypharmacy, low health literacy, complex regimens. We'll go into it a little bit more on the next slide. But the Marquee Toolkit in particular does recommend that we identify high-risk patients right at admission. And they have a couple tools that we can look at for that. So with the high-risk patient population, we want to absolutely make sure we prioritize extra counseling and additional follow-up post-transition. So again, these are some of the populations that are at higher risk for adverse drug events or errors. This includes older adults, low health literacy rates, polypharmacy, complex medical conditions, behavioral health conditions, children with special healthcare needs, cognitive impairments, coexisting disabilities, lower socioeconomic status, newly admitted to a long-term care facility, ricket movers, and persons lacking stable housing or medically underserved. So again, these folks we may need to provide a little bit more attention to in terms of counseling and post-discharge follow-up. Right, and going into the patient case, so we have MP, who's a 78-year-old woman who has a past medical history of type 2 diabetes, hypertension, chronic kidney disease stage 3, tremors, poor vision. She's on insulin, lives alone, but her daughter visits twice a week. So it is noted by the nurse in the hospital that the patient has not been checking her blood sugar due to issues with her vision. And she's also been having trouble administering her insulin because she has vials currently. So the plan for the patient is to start a CGM, which is covered, switch the insulin vials to pens, and to educate the patient and the daughter, document all of the instructions, et cetera, in the discharge summary, and make sure that the patient has a follow-up set up with their primary care doctor. So in terms of this case, this kind of highlights interdisciplinary teamwork. And if we go to the next slide, we can kind of see how each role played a effect here. So in terms of the nurse observed that the patient could not check their blood glucose and had trouble drawing up insulin from the vials, recognized that this is a risk after discharge. And that's when the physician came in, consulted the pharmacy, and sent appropriate prescription to the pharmacy. When pharmacy was consulted, they made sure that the CGM was covered by insurance, et cetera. The patient wouldn't have any issues or barriers in terms of picking it up. And then provided education on the use of insulin pens and the CGM. And the case manager helped us out with the insurance as well as the DME portion of it. In terms of key takeaways, keeping in mind that medications are common, but definitely preventable, and collaboration is key. Each discipline has a distinct role, and at the center of this is our patient and ensuring that the patient gets the optimal care. Looking at our processes and standardizing them definitely helps with safety and consistency. If we can and have the opportunity to identify high-risk patients early on, utilize the teach-back method in these situations, and make sure that communication is really strong in order to reduce readmissions. Anything to add, Fung?
No, you're good. You highlighted basically
Okay.
the key points really is to know that like the medication errors are really common and there's ways to prevent it and there's different strategies, and making sure that you tap into your resources using the interdisciplinary team.
And then we've included some helpful resources here for you, both the toolkits that were mentioned in the presentation. Feel free to check them out, and these are our references.
What questions do you guys have for our section? There's a question in the chat, how common is overprescribing and who and when are the best time for deprescribing? That's a great question, Michael. I don't know if you want to start. You want me to start, Kapali?
I can start. I feel like overprescribing is more common when the medication reconciliations aren't performed or conducted. And I would think of it more like a duplication, or, the patient, again, is seeing several specialists and has several medications that are kind of doing the same thing, et cetera. And in terms of deprescribing, I would hope that will happen at like the next medication reconciliation or at whatever point the patient does get a med rec. But in terms of deprescribing in general, it really depends on what the medication is and what outcome you're ultimately looking for. Are you trying to avoid an adverse drug effect? Do you feel that the medication is not necessary? So really a conversation to have with your pharmacist and doctor.
Yeah, I would say deprescribing really should be looked at honestly every time because we don't want the patient to be on things that they don't need to be on, especially being able to cause adverse effect. I know there's a huge thing about deprescribing for geriatric patients, but really when I think about my patients who's basically younger than like in the 40s, 50s, 60s, I try to deprescribe if I can, but sometimes the patient needs to be on what they need to be on. So personally, I think you should look at basically ensuring that the patient's on the appropriate medication regimen. And that might mean that you need to add more medications, or that might mean that you need to take out some medications because it's not working properly or patient doesn't need it anymore. We have a question, would you say VNA for med adherence will also be helpful for daily injection, especially if recently discharged from hospital with new orders? So VNA would be very helpful. So when I was still in the hospital setting, sometimes I would try to vouch for patients to get VNA if I feel like they're struggling or they're going to struggle going home with whatever medication regimen it is. Sometimes just having someone there temporarily to assist the patient can also help. So if that's a resource that's available and that's something that the patient can get, that's certainly something that I would recommend. I work in home care and often find the biggest issue is the hospital makes changes, but the patients go back to the original home dosing meds. The PCP signs orders for VNA, but they don't always know what the changes are. Thoughts on how to make this easier? I think the biggest thing is, I'm assuming that you're a VNA. If you have information that the patient has been discharged from the hospital, to provide that information to the primary care provider. So if you're able to get a discharge summary from the hospital and send it to the PCP, that would probably be the best, because a discharge summary basically communicates to the next provider in terms of what happened during the hospital stay and what changes had occurred. Patients usually get a discharge instruction, which is not as detailed, but the instruction does have what the medication changes are in those sheets. So if you know that your patient were discharged from the hospital, I would say that see if they have any paperwork that they brought home, and then that can be then hopefully shared to the primary care provider so that they're not on inappropriate medications. Like you're saying, sometimes patients go back to the home medication, even though things change in the hospital because maybe they weren't educated properly. And so I think being able to access the discharge summary or the discharge instruction, and then obviously communicating that with your patient, but also sharing it with the primary care provider. Sometimes from hospital to home doses differ since their diet is that much more controlled. That is true, especially around insulin. And so that's why it's important for patients to get in to see their primary care provider within that week. Because things change when they get home. So for those who've seen the patient in outpatient setting, it's important for you all to emphasize that, because things might change and the patient's need might change once they leave the hospital. What checks are in place upon discharge to follow up that patient is able to pick up medications from the pharmacy? For example, patient in hospital for DKA but never picks up insulin or is not prescribed insulin pen needles with insulin pen. I can tell you that it really depends on where they got discharged from. So in Massachusetts, luckily, we have health systems where hopefully if your patient get hospitalized, they're hospitalized in a health system where they go see their primary care provider. That's best case scenario. Worst case scenario is that they get hospitalized at a hospital that's in a different health system than their primary care provider. I think that what checks are in place really depends on the institution. So there's some hospitals that have more robust post-discharge connection and touch with patients than other institutions. And so when I was working doing transitions of care, back then at the hospital I was at, one of my role was to give a patient a follow-up phone call post-discharge to check in on them, see if they made their appointment with their primary care provider, see if they have any issues with the medications. And I know that a lot of institutions are doing it now, but I don't know to what capacity. But then there's also certain hospitals that have a pharmacy in there. And so a lot of hospitals that do have an outpatient pharmacy, there's a program that you might hear of being called Meds to Bed. Basically, discharge medications are being dispensed in the outpatient pharmacy that then gets brought to the patient's bed before discharge. So they actually get the medications in hand before discharge. This isn't at every single hospital. It really depends on the different hospitals and whether they have that resource or not. Kripauli, I don't know if you want to add to that or to
Yeah.
that.
Yeah, I think like Fung was mentioning, Meds to Beds programs, et cetera, are really great, but they're limited to the institution if the institution has it, et cetera. I think, you know, if your institution has a pharmacy in-house, but they don't have an official program, I think it's great to start working with them. And I always tell folks in the hospital, et cetera, it's nice to just pick up the phone and call someone. I know it's harder to do these days, but even if it's CVS pharmacy, et cetera, just giving them a heads up, letting them know, hey, the patient's coming in with a couple of changes. Can I just make sure they'll be able to pick these up, et cetera? I know we're really have a lot of time constraints, et cetera, but if we are able to, especially for our high risk patients, that's something that can be really helpful.
I know we're running on time, so
Yes,
if you have
thank
any
you.
questions, feel free to drop it in the chat. But I
Absolutely.
know our next presenter needs some time to present too.
Yes, Amy and Alyssa, it's all you. Thank you, Fun and Kripalu. Thank you so much.
Oops, sorry, I was still on mute. Thank you so much. So hopefully you'll be able to see my slides. They should be popping up shortly. But
You look
Alyssa,
great.
perfect. Alyssa and I will be kind of transitioning over to some helpful tips and tricks for medication management across care settings. So we heard from Fong and Kripalu that our diabetes patients are going in and out of different care settings, and those transitions can be hard. And all of us are working in all different areas and have different expertise. But no matter where you're working, your patients with diabetes are going to be coming with medication questions or asking everyone questions. And so we wanted to be able to help connect you with some helpful resources that we use in our practice to help with some of those questions. Alyssa and I do not have any disclosures today. If you would like to pay us at any point, we are very open to that. But as of right now, we do not have any disclosures. Our objectives are here. I'm not going to read these to you, but like I said, we're going to be going through some common resources and, like I said, tips and tricks for medication management. So our slides will alternate between what we call our Diabetes 101 slides and our Hot Topic slides. So our Diabetes 101 is more of our tips bag, if you will. And so we are going to provide you with some quick resources to review basics with patients, caregivers, or other team members. So again, no matter what setting you're in, patients are going to come to you with questions about their diabetes, about their medications, even family members, right? They just know that you are healthcare adjacent and they start asking you all these questions that may not be in your day-to-day practice. And so where are some resources you can send patients to get the information that they need? And we'll alternate that with our hot topics, which is more of our tricks bag, if you will. And these are questions that our patients are coming to us in clinic asking us about that are timely, that they've seen on the news, that they're hearing about from their friends and loved ones, and some resources that you can direct them to or information you can provide to them that is accurate and up to date about those hot topics. So without further ado, I'll start with a Diabetes 101, which is just some helpful resources for the basics of prediabetes, type 1 diabetes, type 2, and gestational. So you will be sent a copy of our presentation after the CE, and all of these pictures are hyperlinked. So if you want to be able to go and download these resources, we've linked them for you. You can click on the picture and it will bring you to the PDF that you can then download, bookmark, print out, and give to your patients. And these are just handouts that we've found that are helpful to get back to basics with your patients. So I'm sure a lot of us have encountered a time where we're working with a patient who may have had diabetes for a long time, and you're realizing, oh wow, like we need to start back over. We need to go back over some of the basics to help you engage in your care. Or we have some newly diagnosed patients, especially our gestational diabetes friends who are just getting this diagnosis at a stressful time and trying to navigate that. So these are some really great resources that we've identified. You may also have resources from your practice site that you like as well. And so I really would love if you could fill our chat with links to resources that you found really resonated with your patient or has been really helpful to you in helping review some of these basics with your patients. So these are just the ones, like I said, that we find are helpful. We're looking for resources that provide adequate readability, understandability, and actionability. And I know those sound like made up words, but in the health literacy space, these are real things that you can assess your handouts for to make sure that they're appropriate for patients. So readability would be looking to make sure that they're at an adequate reading level for your patients. There's tools like a Flesch Kincaid reading grade analysis that you can do, and there's tools for understandability and actionability like the PMAP-P. So we've done these tools on these handouts before, and they're not the best, but they're kind of the best that we've identified so far, along with the content that we like to cover in our teaching. And so we know that these are going to be kind of helpful for your patients, even if they may have a lower health literacy, especially if you chunk the material and use teach back techniques with them. So again, please in the chat, dump in the other resources that you like reviewing with your patients to get back to basics, or quick things that, again, your family member just got diagnosed and wants some quick information about it. A link that you could send to them would be great. A hot topic that we've been seeing come up more and more is this topic of Ozempic babies. And so I know I was at clinic the other day where a patient came in and was like, oh, you started me on the Ozempic and you didn't tell me I was going to get pregnant. And I was like, whoa, like, what do you mean? I'm one of my other passions is pharmacist prescribed birth control. Like, I usually don't like pass up an opportunity to talk about birth control. So I'm looking at her chart and she is postmenopausal. So I was like, I'm so sorry, but let's review where is this question coming from? And she had heard it on the news about how everyone was having Ozempic babies. You can see in the picture there were all these news articles coming out about this increase in fertility that patients were experiencing. And so we wanted to take a minute just to help debunk what's going on and provide you some information about this hot topic. So we know that this problem, or what's happening, is kind of twofold. We know that weight loss can help improve infertility, especially in patients who may have diabetes, where other conditions like PCOS kind of have similar pathology. And so we know that that could help improve their fertility. And so what we are seeing is that a lot of these medications are helping patients to lose weight, and then they may be experiencing unintended pregnancies if they weren't taking adequate steps to prevent. The other thing that we're seeing is that even if they were taking adequate steps to prevent, some of our GLP-containing medications can interact with hormonal contraception, specifically our oral contraceptive pills or your classic birth control pill. And so you see in this table, we've had some studies come out around this that were looking at these clinical interactions, and we saw tirzepatide, exenatide, and lixisenatide all have clinically significant interactions. And there's recommendations there about how to navigate this interaction between the medication of the GLP and an oral contraceptive pill. Perhaps you need to space out the timing of taking it or switch to a non-oral contraceptive like an IUD or implant. We also know that some of the other GLPs do not have clinically significant interactions when they did the studies. And so our semaglutide, liraglutide, and dulaglutide all did not have interactions. So patients can continue on their birth control pills while taking these medications, but just be really cautious with missed doses, making sure they're following all of the recommendations, because an unintended pregnancy could occur due to that improved fertility if the adherence to the oral contraceptive pill wasn't exact per recommendations. I'm going to invite Alyssa to talk now more about her Diabetes 101 and hot topics.
Okay, so our next 101 topic was patient handouts for hyper and hypoglycemia. I know in clinic this is one of the topics that I probably spend the most time counseling on, and we do it repeatedly, right? With the same patient, we're assessing for hypoglycemia in each visit, we're providing counseling in each visit. And it's a multi-step process, and it can be something that it's hard for patients to remember, especially in the moment when they're panicking and they're having a low blood sugar at home. So these are two of our favorite handouts. They're both from NovoCare. They have them available in Spanish as well, which is particularly handy for our patient population, and I'm sure for yours as well. But they're at a great literacy level. They have all these little cartoons with the different symptoms of hyper and hypoglycemia on each handout. One thing we love to talk about with the patients is these symptoms could overlap maybe with high blood pressure symptoms, or some of the hyper and hypoglycemia symptoms overlap again a little bit. So distinguishing with the patient what's their bodily cue, the likelihood that they're going to experience the entire spectrum of symptoms is pretty much nil. But what's going to be your bodily cue? What do you know that you experience when you're having high high or low blood sugar. And then on the back side of each handout is the steps to take. Obviously, there's less kind of treatment recommendation around high blood sugar, but the rule of 15 is explained really nicely also with pictures on the back of the handout for hypoglycemia. And so it's something I send the patients home with, and I say, stick this on your fridge. So in the moment when you're not feeling well, you can reference it and kind of go back to the steps that we went over in clinic today. And like Amy said, when you guys get the slides, we did link each of the handouts here, the English versions, but you can find also easily the Spanish versions on the website as well. So our next kind of hot topic, things that patients, especially my younger, more tech-savvy patients, are asking about are diabetes management apps. So the ADCES has a really great resource that has a number of different applications linked. These are some of the ones that have come up more in conversation with my patients or are a little bit more top of mind. So one of them is called MySugar. It has different interfaces to input your blood glucose levels, what foods you're eating, insulin and doses of medications that you're taking, activity that you're performing, to kind of track them all in one space. The Blue Star app, on the other hand, is more of a coaching app. So in the paid version of this app, they all have paid and free versions, but in the paid version of the Blue Star app, you're paired with a clinician who kind of coaches you and provides some feedback in response to the blood sugar data that you're inputting. So for example, it might say that I see your blood sugar's been running high. Have you been missing doses of your medication, or has your diet changed? So it has a little bit more interaction between the patient and the clinician built into the app. The DNAV app is unique in that it's a prescription product. It's an FDA approved as like technology as medicine. And so in the app, you're actually inputting what doses of, you're inputting first what time of day it is, what event. So for example, in this example, it's dinner time. And then it's customizing kind of what dose of insulin you should use in response to the other variables that you've put into the app. And then lastly on the screen, the Happy Bob. This is a Dexcom product. So it pairs with Dexcom G6, G7 sensors. And it's trending your blood sugar the same way you could view in like Dexcom Clarity or the patient's Dexcom app. But it kind of gamifies it a little bit. You have this little Bob character who has different faces, whether your blood sugar is low, in range, or high. And you also are collecting stars in different points along the way for time you spend in range. So again, that's a Dexcom product. It pairs with the Dexcom CGMs, but again, kind of gamifies their diabetes experience, make it a little bit more fun.
Awesome. Our next Diabetes 101, and again, please feel free to contribute your own handouts, is things about medications. So within the resource that I talked about for type 2 diabetes on the first Diabetes 101 section, these in there, there's a whole section on medications, and it shows the patients the body and where the different drugs work, which is really helpful in trying to explain to patients why they may need to be on multiple diabetes medications, showing them the different areas of the body that they work. And it also goes through some potential side effects and important clinical pearls or questions they should ask their provider about. So it has great information there that you can help go through each medication class with your patients. The other question that comes up all the time is storage and expiration, especially with our insulins and non-insulin injectables. And so this resource here is kind of a quick one-stop shop that has all of the expiration dates and all the storage. I know our pharmacy is guilty of it, of whenever we have a refrigeration product, it gets stamped refrigerator in big red ink, and it goes all over the patient's handouts. And what a lot of patients don't realize is just because it's being stored in the fridge in the pharmacy doesn't mean that you can't take it out of the fridge. And so many diabetes medications, even though they are refrigerated to start, once open, you can leave at room temperature, right? And so it will help our patients being able to help remember their medications if they can keep it somewhere out of the fridge where they can see it, or it can help them with some of the local injection pain if it's not as cold when they inject these medications. But the downside is it is very product specific. So there's no easy way to remember it. And so having a tool like this at your hands to be able to look up storage and expiration can really help in all settings, help your patients manage those refrigerated products. Another hot topic that we see a lot, especially because we're at a FQHC, is helping our patients get access to medications. So a lot of you may be familiar with GoodRx, but there's also other programs like Needy Meds or Rx Assist that you may not be as well versed in. And so these three are tools to be able to help identify patient assistant programs or medication coupons that can be used in the pharmacy. And so they're really easy to navigate. So the picture here is of Needy Meds. You can search by the drug. So let's say the patient needed help getting tirzepatide access. You can search that medication and it will pull up some resources to help look into, at least, to see if you can get it as an affordable way for that patient. Getinsulin.org is similar, but it's specific to insulins, and you can either do an urgent request or an ongoing request. And then findhelp.org is for kind of everything. So it includes medication assistant programs, but it also helps with other social supports that our patient might need. And so we were in clinic the other day and one of our pharmacists chatted and was like, I know sometimes I go off topic with my patients, but they need help paying their utility bills. Like, where can I go to help this patient with this? And so findhelp.org is one of those resources that you can use. I don't want to make this sound like it's magical and you're going to get everyone to be able to get medications for free and no one has to pay their light bill anymore. There's lots of eligibility criteria that you have to sift through. So it's not a perfect system. But for the patients that you can help, these are really great tools to be able to help them get access to some of these things that they may need.
Okay. Then our last Diabetes 101 topic was various adherence strategies. I put front and center on this slide a picture of our boxes, which we call med boxes. But I know there are a variety of local pharmacy programs that might be able to help your patient package their medications in a more easily understandable, better organized way so that they can adhere to the medications the way that they're prescribed. One of the big plugs for our MedBox program is that on the back, it's printed in English, Spanish, and in pictures. So it kind of spans a variety of patients at different literacy levels. So check with your local pharmacy, see if they offer something similar as well. Some of you may be familiar with a program via MedMinder, which is mail order. Not all programs, I know, for example, the MedMinder program are associated with a cost. So that's one thing. The local pharmacies sometimes are able to offer these at reduced or no cost to the patients, like our in-house pharmacy. So little plug for the local pharmacy programs and their different adherence packaging. But an OTC pill box can do the same thing, especially if the patient or someone in their life is able to organize them effectively. I pictured here one, again, that has options for multiple daily dosing, which I think is helpful. Having one pill box standalone for AM and a separate one standalone for PM often contributes to errors where patients are taking the wrong medications the wrong time of day. So something like this where it's all set up can be helpful. And again, we liked this one because it's available in pictures, so it can help patients kind of regardless of their literacy level. Outside of this, for sometimes younger or more tech-savvy patients, there's a variety of applications that can help keep a track of your entire medication list so you have it handy, where you can input when you're taking the medications, if you missed a dose of medication. I listed some of the three most common, most popular ones, which is DoseCast, MyTherapy, and then the MediSafe app, but there are a number of ones available on both the Apple and Android platforms. And then lastly, going back to the basics, a little bit less tech savvy. I know my grandma, for instance, she doesn't have a smart pharmacy program to pillbox her meds, but she does have an Amazon Alexa. So we've set her Amazon to like remind her around noontime, lunchtime, like remember to take your insulin with lunch. And that's something that's been helpful for her. The other thing is if they have really no technology, no desire to kind of interface with any technology, alerts, alarms, associating your dosing with daily tasks is really helpful for our patients. Let your routine be the reminder for yourself. So in clinic earlier this week, I was talking with a woman who wakes up every morning, brushes her teeth, and goes downstairs to make her cup of coffee. And so we talked about keeping her morning meds next to the coffee pot so that her routine is the trigger to take her medications. Versus I had another woman who has like a quilting circle. She's very into quilting. So every evening she's working on quilting projects. She was forgetting to take her bedtime medicines, but we had her put her bedtime medicine in the bucket of supplies with all of her quilting stuff. And she didn't have to worry about pets or kids or anybody kind of getting into it. But that was a good prompt for her. When she finishes her quilting project before she gets ready for bed, she takes that bedtime medication. So just associating dosing with daily tasks can be a big adherence strategy for patients. And then lastly, for a hot topic, Fong and Kripalu were talking a little bit about polypharmacy and med management in that space. I put a definition here for polypharmacy, which is the simultaneous use of multiple drugs to treat a single ailment or condition. I know some institutions will also define the use of any 5+ medications or a different threshold for any condition as meeting the criteria for polypharmacy. So in clinic, we love to substitute individual single tablet agents for combination tablets whenever we are able to. It reduces the patient's pill burden. It sometimes can reduce their out-of-pocket costs because they're paying for one agent versus multiple copays. And it sometimes sweetens the deal when you're talking about adding a medication. But although we're adding an agent, I can cut down the number of pills you're taking in the day, and the patient might be more willing to make the medication modification that you're suggesting as a result. So I put on the slide selected combination medications that are covered by MassHealth without a PA. And some of them we use very often in clinic, like Synjardy. For example, I had one woman who was on metformin ER and empagliflozin already. I wanted to increase her dose of empagliflozin. And by changing her to the combination pill, I was able to get her from 5 tablets a day down to 2 tablets a day, representing those medications. So she was really pleased with that. So combination meds, whenever possible, we do this a lot for high blood pressure too, can be really helpful for patients.